Welcome to another episode of On Target Conversations, a series about metastatic non-small cell lung cancer. My name is Rasheda Persinger, and I am currently the medical oncology lead nurse practitioner at the Johns Hopkins Sidney Kimmel Cancer Center at Sibley Memorial Hospital, and I will be your host for this series. Today, we are talking about how to best support patients with metastatic non-small cell lung cancer to receive the appropriate treatment for their metastatic lung cancer. I am joined now by Tiffany McFarlane, who is a nurse practitioner in hematology and oncology at Weill Cornell Medicine, New York Presbyterian Hospital.
Thank you so much, Rasheda, for having me on today.
Thank you, Tiffany. Before we get started, I should note that this is a promotional program supported by AstraZeneca. It is intended to provide educational information on the identification and treatment of patients with metastatic non-small cell lung cancer. We are speaking to you on behalf of AstraZeneca and have received compensations, but the dialogue is based on our personal clinical experiences supporting patients. As mentioned earlier, we will discuss the importance of educating patients on receiving the most appropriate treatment for their disease, and how healthcare providers may be able to help patients understand the importance of knowing all biomarker test results is critical to informing treatment decisions. Tiffany, what do you tell patients about the importance of biomarker testing at diagnosis and the need to base treatment decisions on the complete biomarker profile for their metastatic non-small cell lung cancer?
With the new metastatic non-small cell lung cancer diagnosis, I discuss with patients that there are usually three types of treatment modalities: targeted therapy, immunotherapy, and chemotherapy. Most targeted therapies are oral, while most immunotherapies and chemotherapies are administered intravenously. Before we start a treatment, it is important to determine whether we can find a molecular mutation, such as EGFR or ALK, or an immune biomarker, such as PD-L1. We let our patients know that this information helps us determine if their cancer is sensitive to targeted therapy or immunotherapy. If neither is the case, then chemotherapy is likely the treatment choice. Biomarker testing identifies patients who are likely to respond to targeted therapy and immunotherapy, while hopefully provides patients with better treatment outcomes.
I too share a similar approach in discussing this topic with patients. In our practice, the patient receives the initial information from the oncologist with an immediate same-day follow-up from the nurse navigator. I typically have the educational discussion with patients after they have had time to process their initial appointment, and then they call or message with questions. Currently, we use this opportunity to reiterate the definition of a biomarker profile and the importance of basing treatment decisions around it.
I think that's such a great approach. Ultimately, it is essential to test every patient in the metastatic non-small cell lung cancer setting for actionable mutations, irrespective of patient demographics. This is key since it is not uncommon to see EGFR mutations in a wide variety of populations, including non-Asians, males, and smokers. So if we relied on patient demographics and smoking history alone, we could miss a percentage of patients who may benefit from targeted therapy.
That is a very great point. And as we know, up to 60% of patients with metastatic non-small cell lung cancer may never have the opportunity to receive a second-line therapy for various reasons. Given this, obtaining a complete biomarker profile helps to ensure a patient is provided with optimal first-line therapy with the goal of improving treatment outcomes. Our discussion thus far highlights the importance of ensuring all test results are obtained prior to initiating treatment. Initiating certain therapies prior to having a complete biomarker profile may delay or prevent the use of optimal treatment options. National Comprehensive Cancer Network Clinical Practice Guidelines in Oncology, also known as the NCCN Guidelines, recommend biomarker testing for EGFR, ALK, ROS1, BRAF, MET exon skipping, RET, NTRK, and PD-L1 because first-line treatment decisions for patients with metastatic non-small cell lung cancer should be made based on biomarker test results, if clinically feasible.
Precisely. Specific first-line targeted therapies are recommended in the NCCN guidelines for eligible patients with metastatic non-small cell lung cancer who have specific genetic alterations.
Correct. For example, for patients with metastatic non-small cell lung cancer who were identified to have EGFR mutations, EGFR tyrosine kinase inhibitors, also known as EGFR TKIs, are the NCCN guideline recommended first-line therapy. And it is important to note the identification of EGFR and additional actionable mutations can be assessed by using both tissue and plasma testing.
And just to elaborate on what you said, if there is insufficient tissue to allow testing for specific genetic alterations, a repeat biopsy and/or plasma testing should be done. And as we know, the turnaround time of molecular and immune biomarker test results may impact treatment decisions.
Absolutely. Tests for immune biomarkers, including PD-L1, may be received sooner than molecular biomarker analysis. This is important because if a patient with metastatic non-small cell lung cancer finds out their cancer is positive for PD-L1 expression, but their molecular test results are still pending, they may want to start treatment immediately based on their PD-L1 expression alone.
You are so right. I've seen that so many times, Rasheda. And therefore, it's our responsibility to ensure our patients understand why they need to know all biomarker test results and that ideally, first-line treatment decisions should be made based on the complete data from biomarker testing versus the immune biomarker test results alone. It is especially critical because molecular and immune biomarkers can overlap. For example, up to 70% of patients with EGFR mutation positive non-small cell lung cancer can also be positive for PD-L1 expression. And while PD-L1 expression can be elevated in patients with metastatic non-small cell lung cancer who have an oncogenic driver, NCCN guidelines recommend that targeted therapy for the driver mutation should take precedence over treatment with an immune checkpoint inhibitor.
This is such a great point, Tiffany. So with this understanding, how do you talk to a patient who wants to start an immuno-oncology therapy before all molecular test results have been received?
In my experience, I think clear and frequent communication with patients and their caregivers is essential. It is important to emphasize that knowing all test results helps us choose the first-line treatment that may lead to improved treatment outcomes through personalized treatment of a patient's cancer. So while immunotherapy may be an acceptable choice for some patients, immunotherapy is not guideline recommended for first-line treatment of a patient with metastatic non-small cell lung cancer who has an actionable mutation. As stated previously, when explaining the treatment approaches, sometimes we use diagrams to help patients better visualize and understand the process.
Very good point. And as with you, there are a few important points I highlight when educating patients on the importance of knowing all test results. 1, it allows for personalizing lung cancer care for the patient. 2, are evidence-based and supported by the NCCN guidelines recommending utilization of molecular testing to help determine potentially efficacious treatment options, as well as avoidance of therapies unlikely to provide clinical benefit. And lastly, it provides optimum first-line treatment options to hopefully obtain prolonged survival. Overall, I have experienced when patients completely understand the rationale, they understand how important it is to know the complete molecular profile before proceeding with any treatment. Informed treatment decisions are necessary because for patients who have metastatic EGFR mutation positive non-small cell lung cancer, there is no evidence to support the use of immuno-oncology therapy as a first-line treatment option.
This is very true. Immuno-oncology therapy regimens, with or without chemotherapy, have not been studied widely in patients with treatment-naive metastatic EGFR mutation-positive non-small cell lung cancer. A phase 2 study with immuno-oncology monotherapy was ceased due to lack of efficacy after 11 of 25 planned patients were treated, and the objective response rate was 0% in the 10 patients who were EGFR mutation positive. One patient had a response, but repeat analysis of this patient's tumor definitively showed the original report of an EGFR mutation to be incorrect. In that study, 73% of patients had a PD-L1 expression level greater than or equal to 50% in addition to having an EGFR mutation.
More importantly, immuno-oncology therapies are not FDA approved for first-line treatment of patients with metastatic EGFR mutation-positive non-small cell lung cancer. We should remind our patients that EGFR tyrosine kinase inhibitors are the only targeted therapy that are guideline recommended as first-line treatment for patients with metastatic EGFR mutation-positive non-small cell lung cancer. NCCN guidelines note that immune checkpoint inhibitors with or without chemotherapy are recommended as first-line therapy options if PD-L1 is positive and EGFR, ALK, ROS1, BRAF, MET exon skipping, and RET are negative. Tiffany, what are some of the best practices that have helped to emphasize the importance of knowing all biomarker test results prior to initiating treatment?
In my opinion, informed decision-making is an important component of quality medical care. Having and presenting all the facts empowers our patients and helps them to overcome low health literacy or vulnerabilities, and it improves the quality of our medical care. Many patients either come to the table knowing little about their disease and treatment options, while others are well informed but may not know when to use what. In addition, some patients are just overwhelmed with the research from the internet or other sources. So it is our job to fully explain the importance of knowing all biomarker test results prior to treatment initiation.
Absolutely. As we have mentioned throughout our conversation today, proper education and availing ourselves as clinicians to possible repeated questions assists with patients obtaining a clear understanding of the need to know all biomarker test results before initiating treatment where clinically feasible. In closing, the resounding message in this series is the importance of obtaining all biomarker test results before starting therapy. In addition, this also serves as a reminder to patients that PD-L1 expression is only part of the full biomarker profile and that cancer cells may also harbor EGFR or other actionable mutations. And while first-line targeted treatment is recommended for patients with metastatic non-small cell lung cancer who have actionable mutations, we can let patients and caregivers know that this does not prevent later use of checkpoint inhibitors with or without chemotherapy. At this time, I would like to thank Tiffany for joining me today.
It was a pleasure being here, Rasheda.
I would like to thank our audience for listening and hope you will tune in again soon. To listen to more episodes of On Target Conversations, a series about metastatic non-small cell lung cancer, please visit the web address as it appears on your screen.